When I was 5, you would see me in the kitchen, seeing my parents go through that hospitality experience. It was very unstable, sometimes like paycheck to paycheck.
When you want to become a doctor from Pakistan, you stay away from maths. Why did this happen? Maths to medicine. Do you think, looking back on it, it was the right decision to leave surgery?
I only have one life, and if I'm true to myself, it's what I wanted to do. But there's this saying in business that sometimes you've got to burn the boats.
What is the idea behind Heidi?
You can now share like an AI doctor in your pocket. Like you can share the resident with the patient. You should just try it. It's like, I think when you do an hour session or a long consultation and you click stop and you see it just spit out your note, it's mind blowing. Like Bengali or like other very common major languages like Hindu, other things will all be in there.
Often, there's an advice that if you find a problem, looking for a solution would be the next biggest business model. Do you feel that that's a correct statement to say?
Give a word of caution. Like if you look at a lot of the startup literature and like stuff out there, it looks very rosy, but it's extremely difficult. We were lucky enough to get investment from the same venture capital firm. So that's the firm that gives companies money to try to grow as Canva. So their name is Blackbird. So
today I have got a very interesting person that I'm having a chat to. He is interesting on several fronts. He's got passion for maths, but he has also got passion for medicine. He's a doctor, but he's also a tech guru. And now he's been involved in many business projects. And I think his life is nothing short of very interesting for me, reflecting some of the things that he does. So, Tom, welcome. How are you, sir?
Yeah, I'm good. Nice to be here, Rizwan. Thanks for making time for the chat.
So, Tom, we've had a conversation before, and I think that what you've done is fascinating because, I come from Pakistan, and what's the most fascinating thing about you, when you want to become a doctor from Pakistan, you stay away from maths. You stay anything away from which has got to do with digits. Tell me something about yourself. Why did this happen? Maths to medicine.
I think that there's some parts of my brain that are very quantitative. So like I always liked the structure and the I liked problems that could be solved. The feeling of having something that, I don't know, why are all numbers to the power of 2 less than numbers to the power of 3 for n equals greater than 2, or like some complicated problem, and then coming up with a way to prove it was always something really satisfying for me. Like it was like the kid playing with the jigsaw puzzle, but when I'd grown up. And I think for me that was where there's a parallel with medicine. So I think a lot of the doctors that love medicine, there are different things to love, but one of the things that I loved was the problem solving, but in a really impactful way. So it's not just like a, algebra equation on a pen and paper. It's a real person in front of you. And if you solve the problem for them, you're having a big impact in their life.
I think that's very interesting, and I can reflect on some of it because, we had something called theorems when I was in year 9, year 10, I guess.
Yeah.
And they were like, I don't know if you remember theorems, but they were like sort of proving a point, and they were so binary in terms of yes or no that you had to come up with exact specification or equations, now that I remember, a number of years ago. So I think for me and to some extent it improved my language perception, it improved my reasoning, completely unrelated to the theorems, which was entirely, I don't know if it was arithmetic maths or what kind of maths it was, but it improved my just general reasoning with people and language capacity. Now, Tom, I'd like to know, take me back to a 5-year-old Tom. Where'd you come from? What was your childhood like?
Yeah, so I was lucky enough to be born in Australia. I think it's a blessing for all of us that are born here. My parents are both immigrants. So my dad's from New Zealand. He was adopted, so we don't know his exact family heritage, but I think he's from England, Ireland, sort of Anglo-Saxon background. And then my mum was from Italy, and they met in a family restaurant. So my grandparents,
wow,
they ran a restaurant in Melbourne, and dad was a chef and mum was a waiter, and the rest is history. So when I was 5, you would see me in the kitchen or maybe at the bar making Shirley Temples for all the guests. Yeah, like actually one of the earliest memories I have of like medicine in my life was this flip out anatomy book. It was like
yep.
human body in a book. And yeah, I used to look at it like maybe once every couple of weeks. I was intrigued by how my own body worked, and there was some like big puzzle to decode.
Fast forward, you come to a crossroad of life, you love maths, but now you decide to go into medicine. Why? Why would you do that to yourself?
So I've thought about this a lot over time. I think for me, it came from seeing my parents go through that hospitality experience. It was very unstable, sometimes like paycheck to paycheck. And I didn't feel it that much. Like my parents did a great job raising us, but I definitely had the sense that like money caused a lot of stress, and I wanted to do something that was stable, that I could, make ends meet and do something important in my life. So I think now in retrospect, like those were the things that were driving me. I was good at solving problems. I wanted something stable and meaningful, and medicine was just like really ticked all those boxes for me. And also I'd say the doctors in my life were people that I really admired. No matter the problem, they seemed to be able to solve it. So it was appealing to me to apply the skills I had, solving theorems, but in a way that made a bigger impact on the world. So that was like the drive for medicine for me. I think the combination of all those factors coming into one.
No, that's very interesting because, the stability part or having to see that financial struggle in my parents as well. One of the advice which obviously, coming from South Asia and Pakistan, the parents have got a major role to play when it comes to selecting your life choices, career choices, in fact. One of the advice which my father has that, look, doctor never retires and you'll always have a steady source of income, which reflectively COVID and you've seen most of the industries have gone flat, and I can relate to that. Now, moving on. Now, can you take me back a little bit? Like, what were your extra interests like during medicine and immediately after medicine?
Yeah, I think I always had different side hustles going on, I think, throughout my life. And again, like during the last, say, 10, 15 years, maybe I didn't always kind of acknowledge it and think it through deeply. I just sort of did what felt interesting or exciting or right. I think generally the common theme is like seeking learning about new things. Like I was always interested, like, I broke my leg playing basketball, so I couldn't do anything for 6 months. So I learned to play the guitar, and I can still play the guitar today. My dad gave me some old watch, and I became really interested in watches, and I bought and sold watches for a little while. Side hustle, made a website. Yeah, reflecting back, like whether it's during university when I was, doing a lot of tutoring from different high school subjects, and then once I got into medicine, working with the Fraser's medical team to do all of the tutoring to helping people get into medicine, there is like a real teaching curiosity that I still have today. Like I still love learning new things. Like at the moment we're doing lots of work creating our own large language models, and it's like very interesting learning like some new and old things. The old things are like the maths part of me, like matrix multiplication and all the stuff I learned, and then applying it in a completely new thing. And like the basic idea is like, how do we write a good note? Anyway, so it's always been something, I don't know, like just this paranoia that like I might miss out.
Yeah, no, that's right. And it's funny that how relatable your experience have been taught in a different way completely. I did teach to, primary students, primary school student, when I was in year 9, year 10. Going into med school, when I was doing my internship, I taught med students. And then, the journey sort of continued. And I can see the similarities. Like I think as a young person or as a young doctor, for me, it was also creating a side income stream. But you're right. It just creates that sense of responsibility and also that hunger that maybe it may go into something bigger, which is quite interesting in your case because you have not made one thing bigger, but quite a few things bigger. So tell me something about your techpreneurs. Is that a right word?
I think like probably building software is like the consistent interest that sort of strung together the last sort of 10 years, I'd say. So I think I first kind of got interested in it as early as making those watch selling websites. I had to write HTML and like code to try to get the website to do what I wanted to do. And then when we went into some tutoring for medical tutoring, creating marketing campaigns, and then we created like little applications to do different like question generators and all sorts of things. And I think the thing that excites me most about just like any tech or software is just one thing I learned from my Fraser's tutoring experience was that it has like a scale of impact that is beyond your one-to-one interactions. So I built this tool that people could practice writing essays with, and after like a couple of years, pretty much everyone in Australia that prepared for the exam was using that tool. I think that was the start of it for me, like just these side projects during tutoring. And then as I went into medicine, seeing some of the problems and things that really frustrated me, I could easily see how like some of those skills that I previously built and learned about could apply to those problems that I had in medicine. So whether that was preparing for OSCEs with Oscar, like a product, or of course Heidi, trying to give every doctor like an AI resident. Like,
wow, that is great.
So that's I think the tech part of it, it's not so much about the tech itself. Like I definitely didn't set out in my career to be like a tech CEO from high school or something. It was more like I had all these problems that frustrated me so much, and I thought I could solve them. Like live the problem, and then software is just an interesting way to solve the problem. And actually, it's not always the way. Like sometimes the behavior change you're trying to create, like you're trying to get doctors used to letting a system draft their notes for them rather than writing as they go. Or
there's an advice that if you find a problem, looking for a solution would be the next biggest business model. Do you feel that that's a correct statement to say?
If people are interested in software or technology, I think it's important to first ask, and I did this with myself, like, why are you? Like, why are you the right person to solve this problem? And why doesn't this already exist is another important question, because there are lots of, because usually there's people talk about like first level and second level thinking. So first level is like, it's just because there's not enough interns in the hospital. But then the second order thinking might be that, well, there's some structural reason why there's not enough interns, and even if you had a way to get more, it wouldn't solve the problem. I would always suggest like spend enough time really living the problem. Like I see people who are medical students who drop out to try to start companies. I think it's a bit too early. Like I was a registrar when I finally made that decision, and so I've worked in the system for long enough to see, I think, and some would argue maybe even I didn't work long enough. Like maybe you have to be a consultant to really understand the system enough to introduce solutions for it. Without a doubt, finding problems that are unsolved and having a really unique perspective on how to solve them is the way to create enormous value.
I've got a question for you, Tom. Now, you managed to get into vascular surgery, and I think it's a pretty strong decision when you were reflecting on leaving during your training. First of all, surgery to get into, it's very hard. We all know that. And it's very competitive. You put lots of effort in as a intern, resident medical officer, senior resident, unaccredited trainee registrar. Do you think, looking back on it, it was the right decision to leave surgery? I mean, how do you feel about it? Just to say, like, what did you feel about leaving surgery? It must have been a very tough decision.
I mean, so just to clarify, so I never actually got into training. So I was still an unaccredited registrar, but I definitely, don't get me wrong, I'd put lots of time and effort in. So I'd sat the GSSE, I'd done every course, I'd done research. So I was getting there.
Yes.
But yeah, I mean, look, if you ask my parents, if you ask some of my friends, they probably still think I'm crazy. I think I ultimately got to a place where it was very existential, like philosophical. Like I only have one life, and there are a lot of vascular surgeons in the world. But what am I really good at? Where can I say that maybe my set of skills is uniquely placed to do something very well? And I really thought, and I still think and believe that I'm uniquely placed to build amazing AI software for clinicians. Like I've got maths background, built software before, been a clinician, worked in rural, regional. Because I worked in Australia, I worked across all the different types of settings. So I did a bit of general practice, worked as a medical student across plastics. Like I got a very good breadth of experience, whereas clinicians in the US just jump straight into a residency program. a lot of clinicians that build software companies never actually did the software themselves. So they work with outsourcers or people they can't trust. So it was really like, this is a problem we're solving. Like in 50 years time, when I'm old and doctors are walking around the hospital, they're going to have AI software or software that does the stuff that currently interns spend all their time doing, like clicking around the software, figuring out where to submit different forms, writing notes that include everything what was discussed, suggesting different clinical decision support, like reference guidelines, things from the hospital. Like some software is going to do it and someone is going to build it. And I only have one life. And if I'm true to myself, it's what I wanted to do. So it was kind of a selfish decision in a way. You know, the safe choice was definitely to keep on grinding, get onto the program, complete my training. But there's this saying in business that sometimes you've got to burn the boats. Like you've got to leave like no other options. Like failure is not a choice. Like you have to win. I burnt the bridges. It's intentional. We're not going to fail at Heidi. Like it's not an option. And yeah, I feel happier and more excited going to work every day. But I definitely miss some parts of it. I miss admitting patients. I miss the parts of doing surgery and like feeling really satisfied after you've done a good job. But the parts I don't miss are the parts we're trying to solve with Heidi. So yeah, I think time will tell, you know, whether it was an intelligent decision. Like when I write my autobiography, I don't regret it. I think it's the right move for me. Even if Heidi were to fail, like I would still probably pursue like a non-clinical path, I think, just because it's what I'm better at and what I get the most joy out of.
That's good. I think my next question is, I think built on what you've just said, and it's actually two-part question. First of all, I would like to ask you that very conscious awareness from all the physicians that, you know, AI is super bad. It's going to take their jobs away. Most of the jobs in cancer care and oncology, diagnostic plus radiology, and even emergency medicine, my field, is going to be replaced by AI in some shape or form. So do you feel it's a valid concern?
Yeah, I think there's probably two different perspectives to take with this situation. So I think if you think about like a super intelligence that is thousands of times more intelligent than humanity, then that's something to be scared of. You know, that's something where it can, down to like the subatomic particles, simulate and process and compute what's going on with a person. They don't need to examine the person because it can do a bottoms up simulation of the person. I know I'm getting a bit nerdy, but like stay with me. So like at that level of intelligence, then you get into like philosophical conversations about like, what does it even mean? Like, what is an economy at that point? Like, what is productivity? Like the whole basis of us earning money,
it's gone,
is being meaningful and useful. So if there's some system or software that is infinitely useful, you know, what do we even do? Like, do we just get universal basic income and go enjoy and live our lives in a brave new world?
Oh, that's scary. Universal basic income.
No one wants that. So like, I definitely don't want that, but I don't think that's where we are. So we're at a place where a very limited single modality, this is like your large language models, ChatGPT, is still definitely subhuman intelligence, but on some tasks is like roughly as good as a very diligent human or intelligent human. Like it's like the way these systems work, it's kind of like the average of all of this, the content and different things it sees. So I see that as like a massive opportunity. That's why like when we talk about Heidi, we talk about it as an AI resident. It's about putting the clinician in the center of that experience. Like I don't think you can disrupt the patient-doctor relationship. If I'm unwell, I want to trust the human in front of me. I can't put my computer on their femoral artery and detect whether or not there's a pulse. You know, there's elements of medicine that are immutable. There will always be human clinicians. Even if the human clinician is relying almost entirely on software, I still think the role of the clinician will be there, to be the emotional support system, to be the face of provisioning of care. That role might change, like the way, like whether an oncologist is doing the maths about the right dose or whether a software is making that decision. I don't think that moves the role of the oncologist in that equation. You still need someone who's super specialized, can be a verifiable source for the software that's supporting them, and explain what's going on to the patients.
And it's true. Like, I mean, this is something which we've seen in autopilot. Like, my old man was, a commercial pilot, and there was an autopilot, and it's been around for a number of years, but that has not yet replaced the pilots. And I used to ask my father that, can the plane pretty much fly on its own? He said that plane can actually do that. There's a capability in the technology that it can take off, it can navigate itself, and even land. But there will always be two pilots. Yes, there has been one downgrading of the staff. Like, there's no flight engineer now anymore. In all jumbo jets, there used to be a third panel, which is a flight engineer who used to do flight calculations, fuels, efficiency, engine 1, engine 2. But still, there are still two pilots, captain and a co-pilot. It's not changed that much. Maybe that might be a valid analogy. I don't know.
Like, highly trained people doing highly administrative things will change. Like, that's the flight engineer. That goes away. Like, Heidi navigates the EHR or walks down to the echo department to hand in the form. Like, that's all Heidi orchestrating that. It's just that those highly skilled people get to provide more care.
And maybe, we might be more efficient when we are left to do much more sort of cerebral stuff, thinking stuff.
The bits we like. Like, that's the whole point.
So, coming now to Heidi. What is the idea behind Heidi? And, I'm fascinated by this. My fascination is to the point of infatuation. What is it? And you're constantly referring as an AI resident. I would love to have an assistant at my work as an emergency physician. That would make my life so much easy. Tell me, what is it? How can it help senior doctors, junior doctors, and what's going on in here? And why is it called Heidi?
I'll tell you why it's called Heidi at the end. So you have to stay on. Yeah, I think so.
Okay.
So the mission with Heidi is pretty simple. How do we get clinicians to deliver world-class healthcare in half the time? So to do that, you have to get rid of all of the wasted effort and time spent on things that aren't delivering great healthcare. So when I was a doctor, that's stuff like waiting on hold to get a Medicare approval number or a government approval number for a medicine. It's figuring out how to navigate through whatever EHR you're doing, clicking through all these different screens, waiting for it to load, to prescribe or to create letters. It's summarizing the encounter. It's being on the phone talking to different consultants about what you did with the patient, referring to others, like all the things that aren't listening to the patient in front of you, examining them, thinking about it, synthesizing, coming up with a plan. That's medicine. Doing a surgery, doing a procedure, that's medicine. The kind of in between on the edges, the stuff that takes up like 50-60% of our time is where Heidi should play. So today it's a free note writing app. Unlike the million options you've probably seen, we've been at this since almost 2019 when we first started the company. So we have a big mission that is behind it, and making the scribing, note writing thing free is part of getting AI into the hands of as many clinicians as possible for us. That's the goal right now. It's not about trying to make all this money on this little hobby project. We want to start with note writing, and then there are second and third acts. To hint at what they are, the second act is going to be really like think of it as a kind of like a software-based resident that can do things in your EHR. So you transcribe the consultation with your patient. You click start, records the visit, you click stop. It's only ever temporarily stored. We get the transcript. Heidi, as the AI, knows what happened in the visit, just like you did, right? It listened to the visit, knows what you did, and it can suggest next actions. So it says, okay, would you like to write a pathology request to the radiology department? Would you like to send a summary to the referring doctor? Would you like to send a reminder to the patient in 3 days? And if you click yes, and you approve the action, Heidi will actually go away behind the scenes on a virtual computer and actually do the action on the EHR. Because you don't even need to see the system. It just does it for you. It's your resident, right? Now obviously there's a high degree of trust, lots of things in between to get there, but it's not impossible. Like, we already have a couple of customers in very early alpha already trying this. And basically the idea is you record your visit, it's all secure, compliant, according to all the different standards. Based on the context, sure, we can write a note, but we can also action all the other things that you want to do in the HR. And for high-risk activities, like things like prescribing or other things, we would action it in a draft way, confirm and sign off any actions.
Now, what about the junior doctors? Do you think that junior doctors might be able to use it as efficiently as senior doctors? Like, I mean, you said it's a virtual resident. Is there a virtual intern?
I think so. So for like, even as an intern, one of the things I found most difficult was adequately explaining to senior clinicians like what I'd done. You know, like you're still in the early days of getting used to having an hour conversation, writing a really good note, thinking of what the plan is that comes next. So again, today it's about being really diligent, writing an amazing note, probably better than what they would write. Then Heidi will actually remember everything that happened, and will help them make sure that when they present that to their consultant or to a registrar, they can present what happened accurately and adequately. I think definitely for us, like part of those second and third, fourth acts is bringing in clinical decision support for juniors. So if they are in an under-resourced setting, or this is a nurse or a physician assistant or someone in a rural area that just doesn't have access to someone else, then can they ask Heidi for what other clinicians would have done in the same situation? And we sort of crowdsource, like, yes, like other clinicians, obviously in an anonymized way with all the right consents in place. But imagine if Heidi could say, yeah, doctors like you at the Cleveland Clinic would manage this patient like this.
Wow.
And we show examples, real examples of how doctors kind of finalize their plan on Heidi and what next actions they took. And again, it's still the doctors in the center, right? Like they're deciding. It's not Heidi running wild. You're in control. Having that support available on request. Like if you feel like you're in an under-resourced setting, then maybe we can surface that information to them. I don't think in the foreseeable 3, 4, 5 years, we'll be in a place where like we can rely on the AI to come up with management or plans or other things. It would always be referenced from either sources that we are working with, like Up to Date or BMJ or Dynamed or something like that. Or it would we could crowdsource it from our Heidi users and say, okay, patients that present like this, these are the things that they've done. Just like here's an idea of what you could do.
So you mean to say that the software is automatically learning based on certain behaviors from the physicians who are using it?
Correct. And we still put all these controls in the clinician's hands. So, you know, you can opt in to deleting all of your sessions so there's no record on Heidi. You can do all sorts of things to make sure that you feel comfortable using it with your patients.
Yeah.
So, yeah, it's amazing. Like you should just try it. It's like, I think when you do an hour session or a long consultation and you click stop and you see it just spit out your note, it's mind blowing.
Yeah. Oh yes, I've done a live demo with you. It was actually quite interesting. Now, obviously, patient privacy is a big issue in Western countries compared to where I come from originally in Pakistan, or you know somewhere in India and Bangladesh. You know, the healthcare is in a bit of a state. But I just want you to explain briefly for our viewers, like what measures have you taken? Because you know people get a bit edgy and sensitive about this whole issue of data breach and privacy. How does your software adhere to the standards or the norms which are expected?
Yeah, so obviously this is like the most sensitive thing you can do, you know, recording or transcribing a healthcare conversation. So there's two parts. So one part is just security wise, like how do you make sure that you're secure, that you never hacked. So we have an ISO 27K certificate. So that's basically all of our databases and internal staff and systems have to be audited and built in such a way that it's as secure as it possibly can be, as well as getting externally hacked, like white hat hackers try to get into our database. And we do that on a regular basis. So that's the security side of things. So like, you know, while the recording's happening, it's being encrypted on your device. It's being encrypted while it's in transit. It's only ever temporarily stored. And from a patient privacy consent perspective, so that's more like your Australian privacy principles or HIPAA or GDPR, like sort of how you treat data and what the rules and regulations are there. So we are a Australian privacy principles compliant. We're HIPAA compliant. We're almost GDPR compliant as well. I think general guidelines for clinicians, like I would always suggest, like definitely should consent your patients, you know, like explain, like I'm going to use Heidi. It's going to transcribe our consultation and draft a note. It's not going to store any recording of the conversation. It's basically just for the notes. Are you okay with that? They can say yes or no. That's it. The other key parts are, recordings never permanently stored. It's always temporary. And as soon as the session is done, we just drop the recording. give you options to delete your consult. So if you want to delete the consult notes or what's in there, you can. And yeah, I think that's kind of it. Like doctors have used these kinds of tools for a while. Like, think of your dictaphone or those.
Exactly. I was exactly thinking about that because, I remember when I was a med student, one of the people, like quite a few of our medical students were doing this side hustle of transcribing. So, the physicians in the US don't have much time to, write their notes. So they would transcribe it onto an audio file, and those transcriptions would come over to these tech companies through some sort of audio link. And then the doctor would sit down, or medical student would sit down and record or type what they've heard. So that was called an audio transcription. So that in that day and age, what you've done is just automated the whole thing. And the beauty is that you're saying there's an option of deleting that audio content and then having the note. So at the end of the day, I'm actually left with my note and the audio is completely deletable. So this is like to me, it sounds like a win-win situation.
And like the benefit, everyone always looks at the downside, but the benefit is that you now have really detailed documentation that you might not have otherwise had. Most of the kind of like medical indemnity and other like legal issues that arise, most often doctors don't have any adequate documentation of what happened. They say they did the right thing, but they can't prove that they did ask about the chest pain or they didn't ask about the shortness of breath. So having something like Heidi will ensure that you've covered all those. You'd never miss anything. All the details are there.
This is such an important thing because, in medical, I also do a workshop called Professional Medical Documentation, and the intricacies, despite being very short and despite being very concise, the comprehensiveness from the medical legal reason is just so detailed. And, from an IMG, when they're coming to learn into a new system, you have to learn the medical lingo and then the cultural lingo and all that kind of thing. And if software can help me detail my documents to a medical legal compliance to prevent, because it's often said, if it's not documented, it's not done. So what you're telling me now that the software can actually fill in those little inadequacies which were in my mind, which probably I didn't even check. I did even check whilst conducting my examination. And it can document it, and I can check and edit that information. That is so good.
And I never explained why we called it Heidi. So
yes, I was going to ask that. Why is it called Heidi?
Yeah, so it actually came from an acronym. So we take a patient's history and we get them to a diagnosis. So it was like HIDI, like HIDI, but it's kind of I like naming AIs as a human being. So we had Oscar. Oscar was, this like training AI thing that we use with students. And there's just something like humanizing about it. Like if it's like a robot or a system or something scary, I think it doesn't do it justice. Like this is, an ally, a support, like something that puts you at the center of care. It's not something to be scared of or worried about or like Docomatic or like some other scary name.
Yes.
It's just, it's Heidi, and Heidi's here to help you. And that's it. And we take you from history to diagnosis. HIDI, Heidi, it just stuck.
Tell me what's the future for Heidi? Like obviously and the other thing I wanted to ask, what about the GPs? Can the GP also benefit from Heidi? Because obviously there are far more GPs than the hospital doctors. Do you think that this software can also help them?
Yeah, so or they already do. So we have like everything from vets to dentists to hypnotists to anaesthetists. Like we've got all sorts of different clinicians using the product. I think that's one of our main benefits. We're quite flexible. Like you can basically create any kind of template you want. And yeah, I honestly think anywhere where there's a patient-doctor interaction, Heidi's really useful. We've made it free, like I said, quite intentionally. There's a lot of these kind of, in brackets, like AI scribes that are a 1 week engineer homework project that definitely not compliant, you shouldn't be using, and don't really have like a big vision of what this is going to do to healthcare. They're here for the first note-taking trick. I think what I'm here for is trying to build that real resident. So the next act is having this software-based resident that kind of can do what a resident does in the EHR, starting simple, sending off a path request, drafting a prescription, putting your notes in, creating other documents, like simple actions so that you don't have to go back, sit on a computer and do it. You just press 3 or 4 buttons on Heidi and we go away and do it for you. Then Act 3 is sort of, there's forks in the road, so I don't know what will come next. But Acts 3 and 4, one will be on the patient side, so giving like a great experience to patients, letting you share like your plan. So, how many times have you explained to a patient what your plan is?
Yes. Oh, just yesterday.
So imagine if you could click a button when you're describing your plan, it's actually recording, and then you share that with the patient. They can share it with their family members as well. And now they have a proper record of the plan that you're giving them. And then the other act is for the clinicians, that once we have enough clinicians using Heidi, crowdsourcing this clinical decision support. So, like I'm a cardiology registrar. My cardiologist is not answering. How would other cardiologists manage this patient? Like just queries, letting Heidi, again, using the power of the network to support other clinicians. And then probably one of the fifth acts will be giving clinicians interesting ways to do consultations with patients. So this is probably less for hospital doctors, more for in private practice. Like imagine if after recording 5 consultations in Heidi, we now learn kind of how you take histories, what you care about. You can now share like an AI doctor in your pocket. Like you can share the resident with the patient. Patients can have a chat with the resident. They can start all their healthcare encounters there. And then that resident orchestrates like when do they need a booking? When do they go to the pharmacist? When do you share it with the doctor that shared the link originally? Like a kind of way to extend yourself, like a clone of you that can counsel them, give advice about their plan when you're not there. Now, obviously, that's the most complicated and dangerous one. That's why it's the last. But again, the idea of that is like rather than the patient just chatting to ChatGPT, they can do that, but in an authenticated way. Like it's connected to you. It's connected to the practice. If there are concerning symptoms or features or things that they should really talk to a doctor about, now they're connected to you or they're connected to the hospital. Whereas usually those conversations will be happening in an unauthenticated, unsafe way. So I guess like it's really like residents do that. Residents will explain patients' plans to them, answer questions. That's why I think the resident thing is going to stick. Like if a resident can do it, then Heidi should be able to do it. The only thing we can't do is wheel the computer around. But most of the other tasks we should be able to do.
So GP can use it. And also, I was thinking, and that's a question put to you, that as an emergency physician, lots of patients are waiting to see the doctor. That's the first speed breaker. There are 2 speed breakers in emergency. Time to see the doctor, and then the second speed breaker is the investigations to come back for us to make a decision. Wouldn't it be great that if the patients who are actually waiting in the waiting room have got some sort of AI tool like Heidi as you're describing, to start plugging in their history. So when I go and see them and pick up their file, their history of actual present complaint is already documented for me. I have to just go examine them, make sure everything what the software is documented is accurate, and then make a clinical decision. That will just reduce so much of my time.
We actually, even before the scribe, we actually built exactly that. So we have about 40 GP practices that actually already use that. We call it like the pre-consultation. So we do like the history taking, we summarize it in a note before the visit. So yeah, like all of these things are going to be...
Like simple thing, medication, allergy, social history, like you don't even need a doctor for these kind of things, right?
Agree. It's very structured. It's very algorithmic. You ask the same questions every time. So I think, basically all of these things are going to be stitched into Heidi. That's why we're making the note taking free. Like there's lots of room for us to charge for different things and create different business models. But for now it's simple. Like get Heidi to write your notes for you. It's amazing. You should try it. It's free. And there'll be lots of other cool things coming soon. Yeah.
So on that note, if obviously quite a lot of my customers, as I said, are coming from Pakistan and they're from India and from some of the developing and under-resourced countries, do you think they can use Heidi as well?
So by the time this video goes live, we should have all major languages supported. Currently working on it at the moment. Obviously,
but in its current form right now, if they interacting in English, it should work.
Yeah, English works well. I would expect like Bengali or like other very common major languages like Hindu, other things will all be in there. It's just obviously like very specific, like regional, like dialects, other things might not be covered, but most of the major languages should be live by the time this goes live. Yeah.
And would it be able to translate them into English if it's even taking in Hindi or Urdu or Bengali, you think? Or Arabic for that matter?
Yeah, so that one's a little complicated for us. So, because we're not like a medical translation device, we can't say with 100% certainty that it's accurate. So as long as you know that, like, if we're converting from language A to language B, that you can't really rely on it. Like, it's not the same as a translator in the room. Yeah, like a good example is I remember I was admitting a patient who had a kidney stone, and Google Translate kept on saying that it was rock, like a rock, and I just couldn't figure it out. And then eventually, like, the English to Arabic kind of figured it out. But it'll be a similar thing. Like, it probably won't be a slam dunk. It'll be good enough, but you just have to review it. But yeah, I don't see why not. Like, that'll be a massive superpower. Again, like, I think of it from a place of low resource. Like, if I'm talking to a patient who speaks Urdu and I don't, like, well, what else am I going to do? You know, like, it's better to have it than to not. So I think we'll structure it in a way where we try to make sure it's safe. We give clinicians, like, be sensible, you know, don't rely on it 100%. But yeah, I'm always in favor of making the tools more powerful and then give the clinician the autonomy to decide what to do with it. Yeah.
Thanks. I mean, this is very insightful and I thoroughly enjoyed talking to you, Tom. But I've got one last question before you go. Now, there are lots of doctors like yourself, like, junior doctors, middle grade doctors, and even senior doctors, who would like to follow in your footsteps of, they may have already done that part of having that passion for side hustle, creating a second income stream. And you're an example of making that happen, not once, but twice, but 3 times actually. And I can relate to some of the hardships, building your own company and the finances and the legalities. What would your message be to those young doctors who want to build up their own business or side income despite being doctors? Or would you recommend us to give up everything, or would you reckon it's worth it? How would you advise them based on your experiences coming this far?
First, have a deep, like, conversation with yourself about what do you want to do with your life? What things do you value? What's important to you? Like, what's your mission statement? I think for me, I realized that impacting lots of people was more satisfying than the one-to-one that I could do being a doctor. There's nothing wrong with that. Like, it's so valuable and rewarding, but I saw an opportunity to have a bigger impact. And for me, my value system, that made sense. So I think for any, like, want to be clinician, student, like, you're thinking through what you want to do with your life, I would just be hedonistic. Pursue the things that give you pleasure. If you like some topic or you're interested in it and you're curious, follow your nose. Obviously, don't sacrifice the main thing, the main gig, but just invest time, watch tutorials, get invested in it, start to build up skills. The great thing about doctors is that, we're usually pretty smart people. We're usually curious. We like to learn. So just follow that interest and curiosity. If it turns into a business and you're starting to question, like, where do I spend my time? You have this, like, kind of jack of all trades, master of none problem where you're not good in either place. Like, you're not giving enough time to your business. You're not giving enough time to the hospital, which is what I ran into while I was trying to do vascular training and also starting Heidi. Then you have to have the hard decision. And I would give a word of caution. Like, if you look at a lot of the startup literature and, like, stuff out there, it looks very rosy, but it's extremely difficult. Like, it's so hard. It's so much worse than just working a job, and especially starting your own company. If it goes well, all you get filtered is the problems. Like, the idea, like the problem and solution bit and the product bit is the thing that starts it, but it's exciting. So I think if you in your heart feel that being a doctor is enough, it doesn't frustrate you. Like, the system doesn't frustrate you to the point where you want to start a company. Like, you have to viscerally hate the problem that you're living through. If it's kind of like I have an idea, but, like, I kind of also like being a doctor, I wouldn't do it. I would just be a doctor. It has to be like a life mission that you just have to fix this problem. And that's how I felt. Like, I felt like kind of disgusted that I would spend all this time not with patients or doing things that mattered. Like, I had studied for 10 years to be waiting on hold for 10 minutes to explain a plan to someone when I could have just sent them a summary. But like, because of the way it works, like the consultant just expected me to explain it to them. That has to change. It will change. There's no way you can justify that in a world where there's billions of people trying to get good primary care and not enough doctors to provide it. So for me, it was big enough, and I felt like I was a good enough match for it, and I was excited about it that I took the risk. But for most people, I would suggest like a fun side hustle. So like, you know, like kind of dip your toe into the curiosities is the way to go.
Now, one last thing I wanted to ask you, Tom. Promise, it's the last one, is your relationship with Canva. Now, there's a lot of people who know Canva and in every part of the world. And I think you've got some unique relationship with them as well. Can you tell our viewers what's that relationship?
Yeah, sure. Well, first off, I love Canva. We use it at Heidi. So we were lucky enough to get investment from the same venture capital firm. So that's the firm that gives companies money to try to grow as Canva. So Blackbird. So Blackbird invested in Canva, I think in 2010.
Okay.
So a long time, when they were just two people in an office talking about an idea. And yeah, like we're lucky, like we, as part of Blackbird, we get to hear from some of the team, from Cliff. And yeah, I think like the idea of just building an amazing product, making it free, and then charging users that really love it for really features they can't find somewhere else is exactly what we want to do with Heidi. It's the same playbook, it's just for medicine. I think not enough medical software products obsess over making it the clinician's product. A lot of them forced on you from your higher ups. That's not us. We don't employ massive sales teams. We don't take them out for steak dinners. We spend all our money on trying to make this amazing for clinicians.
It's such an inspirational story, Tom. I love it.